Good afternoon, everybody, and welcome to Scale Neonatology, our virtual clinical Grand Round series. I'm Cath Harrison. I'm the UK clinical lead for Scale Neonatology. And for people who haven't joined before, we have a 2-monthly virtual clinical Grand Round, which we talk about topics that are common to us in West Yorkshire and to our team in Uganda. So a very warm welcome to everybody for joining. There are just a few formalities. We're recording the meeting because what we do is we put the recording onto YouTube afterwards so people can see, and Tim will send round a PDF of the slides for people for some ongoing learning. There is a pre-evaluation form survey that you can see in the link in the chat, and we'd be really grateful if you could fill that in. And then at the end of the session, you will receive a post session evaluation, and again, if you could fill that in, that would be fantastic. So we're going to kick off. So there will be opportunities to ask questions, and there obviously, if people have got questions, please do type them in the chat and we'll try and monitor those as we go along. So the format is that I'm going to hand over to Dr. Samuel and Dr. Gilbert from Uganda, who are going to talk about a case and then just a discussion about how they manage babies with jaundice in Uganda. And then myself and Gill from Leeds are going to take over from the UK. So I would like to introduce Dr. Samuel and Dr. Gilbert from Arua Regional Referral Hospital, who are going to start our session with a case and then talk to us about how they manage babies with jaundice. So thank you very much, Dr. Gilbert, Dr. Samuel, you're very welcome.
Thank you. I greet you and call Dr. Mugabe somewhere, an intern doctor, and I'm going to present a case we had on NICU unit about neonatal hyperbilirubinemia stroke jaundice. The objectives of our discussion, one is to recognize neonatal jaundice. The second is on management of neonatal jaundice. And the third one is a discussion in the context. The medical history of the patient goes as follows. That we received a 3-day-old male neonate on 9th January 2024, who was delivered on 5th January 2024 by a spontaneous vaginal delivery with UPGA score of 8 in the first minute and 9 in the 5th minute, still 9 in the 10th minute, with birth weight 2,800 grams at 38 weeks of gestation, and he received routine medications at birth, including hepatitis B birth dose. The baby was delivered to a 24-year-old female, para 2+0, and the HIV status of the mother was negative, the syphilis status was negative, hepatitis B negative. So they came to us on 9th January 2024. Their residence is 7 kilometers away from this hospital. The complaint they came with was generalized yellowish discoloration of the body for 1 day. The yellowish discoloration started from the eyes and progressively spread to the entire body. There were no other deformities on the baby. The baby was able to breastfeed. There was no abdominal distension, no fever, was able to pass stool and urine. On examination, the vitals were, the respiratory rate was 40 cycles per minute, which was normal. The saturation was 94% at room air. The pulse was 149 beats per minute, which was normal. The capillary fill was less than 2 seconds. Extremities were warm. The temperature was 37.3 degrees Celsius. The cord was dry and not bleeding. And the jaundice was extending to the palms and soles, which is, according to Cramer's rule, stage 5. Other systems were unremarkable, meaning there were no positive findings on other examination of other systems. So we did investigations which were fitting in our setting. The first one was especially the basic investigations. The first one was a complete blood count to check for if there is any elevation of white blood cells, any lowering of HB, reticulocytosis. Good enough. Most of all these findings were okay. They were in the normal range as the values, as we can see on our slide. 0.9, neutrophils 2.2, lymphocytes 4.8, platelets 297, which were in the normal ranges. We did the blood grouping, which was blood group O positive of the baby, which is similar to that of the mother. We also did the liver function tests. We did the liver function tests 10 hours after placing the child under phototherapy because of the limitations we had by then. We couldn't do them immediately because of our setting here. There were some limitations. So the baby was placed under phototherapy based on the Kramer's rule of being at stage 5. So the first investigation was done on 9th, the same day, but 10 hours later. And we noted that the total bilirubin was 214.48. This one is kind of elevated compared to the normal ranges. And the second one was done still after 48 hours from the first one. And the total bilirubin was 143. This second one was done for follow-up to see whether it's responding well, whether the unconjugated bilirubin is reducing. We also did abdominal ultrasound to rule out any obstructive causes of jaundice, and also to check if there is any hepatomegaly or splenomegaly, which would kind of show us whether there are signs of hemolytic anemia in the baby. So based on these investigations, of course, there are others we didn't do, like CRP, because of our setting where we were limited a bit. But these are the ones we managed to do. And we came to a conclusion that the baby was having physiological jaundice. So we managed as follows. On day 1, we placed the baby under phototherapy for 48 hours. We also gave neonatal fluid. Yes, it is true the baby was breastfeeding, but because of the fluid loss which occurs under the phototherapy machine, we also added this so that we compensate for that fluid loss by latent heat of vaporization. That's why we gave it at 100 mils per kilogram. We gave also antibiotics. Remember, our investigations were done 10 hours later. So we gave prophylactic antibiotics because maybe there was an infection by then. So we gave ampicillin and Genta because they can also cause, sepsis can cause neonatal jaundice. The baby, we followed up on day 3 with repeat LFTs, and we noted that they had decreased to actually low risk levels. We maintained on phototherapy because the yellow discoloration was still around the trunk and the cephalic region. And on day 5, most of that discoloration had resolved except the sclera, the yellowing of the sclera, the sclera. But we discharged on breastfeeding, warmth. Here, this was the counseling we gave to the mother, adherence to the immunization schedule, and placing the baby under morning and evening sunlight for 1 week. And follow-up was to be done 1 week later in Michu Clinic, which is, the follow-up date was 25th, the same month, the same year. When the mother came, the baby was breastfeeding, he was febrile, he was passing stool normally, and the skin was of normal color. The mucous membranes were also of normal color. So we concluded that the jaundice had resolved, and we gave the mother the same instructions we gave on the discharge form, on the discharge date, except because it had resolved, it was no longer necessary to place the baby under morning and evening sunlight. We were not able to do the LFTs on this follow-up date because still some limitations by then. That was the case. Thank you very much. I hereby hand over to Dr. Aniku.
Thank you, Samuel, for taking us through the case. We'll now proceed at this stage with the discussion in the context of the case presented and our environment. So our discussion is navigating neonatal hyperbilirubinemia in low resource settings, and the focus here is on indirect hyperbilirubinemia. Having looked at the pre-evaluation, that the questions that had interest of participants, we had this introduction that to determine need for phototherapy, you can use different methods which rely on measuring or estimating the bilirubin levels in blood. The best would be a serum bilirubin level, but we know that there are other devices, transcutaneous devices, and where this is not available, or even in the initial stage, you can use the Cramer scale as was described earlier. So the first is the visual assessment, which gives a correlation between the possible serum bilirubin levels and what clinically is on the patient. So the scale runs from 1 to 5, with 5 being very high levels and 1 and 2 being low levels, as demonstrated on the image with the cutoffs. These are available, and I think, but important that it should be assessed in natural light without a yellow background, and the baby should be naked. You can also test for blanching of the skin. However, when you notice that you are in zone 5, zone 4, zone 5, then you should always do a bilirubin test. And this is necessary if the jaundice is on the first day of life, or as I've said, in zone 5, or if you're unsure about the visual assessment. You will realize, even in our case, that when eventually we got the serum bilirubin levels, there was possibly not a similar correlation that we see as in the scale up. But again, we had already started the phototherapy, so there could have been that confounding. But also you need it for monitoring progress. So we eventually, when using phototherapy, when using serum bilirubin, we have the table that looks at guides in the decision process. And Samuel was careful enough not to commit himself to this table, but where this is available, then it is the way to go. It avoids unnecessary exposure of the baby to risks of phototherapy, as we shall look at what the risks are. So where this is available and you can routinely do the tests, then you tailor your decision to the serum bilirubin levels of the baby. And just to emphasize that serum bilirubin levels are the best to assess jaundice, and this is plotted against the age of the baby in hours. And then if the level is above the line for the baby's weight, you start phototherapy. And we would like to learn from other centers what the experience is in use of this tool, since we don't routinely use it. Yeah. Again, just a simplified chart that brings the correlation I was talking about. So what do we have in country? If you look at our neonatal protocols for managing sick and newborns, I'm glad that we now have something which is standard for the country. It requires of us pay attention to jaundice in a baby on day 1 or on days 2 to 14, especially if they have chroma grading 4 and above, or if they are premature. But furthermore, for other causes, especially obstructive jaundice, it talks about prolonged jaundice beyond day 14 or day 21, depending on the age of the baby. The workup is detailed, requiring us to do random glucose, complete blood count, CRP, including those that we have been able to do. And it provides guidance on how to proceed to do phototherapy, or even beyond phototherapy, decision on exchange transfusion, depending on the rate of rise or the response to phototherapy. How therefore is our experience in application of these guidelines? They are relevant and useful for standardization of care. However, it requires us to do regular monitoring. And in our center, we are not able to do exchange transfusion because of technicalities in what it entails. So we would possibly make a decision to refer such a child. However, as is in the guideline, we don't see information on use of immunoglobulins in ABO incompatibility, but there's literature that shows that it does have some results, and in others it's equivocal. So what is the experience elsewhere on the use of immunoglobulins if you have either ABO incompatibility or rapidly rising bilirubin levels where you cannot do exchange transfusion? That is something we would really love to also hear in terms of practice from elsewhere. So we have heard about the management that we undertook for this baby, which was successful, and the baby went home. But in general, for learning purposes, for all babies that come, we need the emergency assessment using the ABCD. And where necessary, you can give oxygen. If the baby has come late and has advanced features, especially where there are seizures, then you manage the seizures and identify and manage dehydration, hypoglycemia, or give fluids as per protocol. Certainly with zone 7, it recommends for us to start phototherapy immediately and treat for sepsis where necessary. And in our case, although the baby did not have severe forms, he did have zone 5, so that was the basis of initiating phototherapy. What does it do? It achieves conversion of insoluble bilirubin into isomers, which are easily soluble and excreted in urine. In order of increasing superiority, you could use sunlight if you are able to have filters for UV light, and white light tubes or blue light tubes. And for us here, we have the LEDs. And importantly, you want to protect the baby's eyes and also use a pamper. During the, what other additional care do you need to pay attention to? Frequent extra feeding. It can be breast or a spoon. In our baby, in the beginning, we had to give extra fluids in addition to the breastfeeding. However, we caution that there is really no need for formula or other oral solutions like sugar water. Important to take note of the weight on a daily basis. Samuel will tell us whether this he adhered to. Also important to monitor urine frequency, temperature. I also like to bring out to the rest of the team on the role of transcutaneous bilirubin measurements for monitoring. We were lucky we dealt with a term baby and he recovered immediately. What is our experience and challenge with the preterms is the risk of causing iatrogenic anemia because of sampling. So how else is the practice elsewhere with the transcutaneous bilirubin monitoring? And that is something I would also like to get to hear from the rest of you. As we run out of time, let me leave this, that it is not without side effects. So caution should be exercised and only given when necessary. Increased fluid losses, skin rash, hypothermia, or it can also interfere with the maternal bonding because the baby is away from the mother and mother cannot stay with the baby under the phototherapy machine. Maybe that is what the IT people, the innovators need to work around. How do we keep baby, how do we keep the mother safe when the baby has to undergo phototherapy? And lastly, in West Africa and Nigeria, we have been shown the use of filtered sunlight as an alternative. Samuel mentioned some challenges, and indeed, yes, some challenges do occur in our setting. Sometimes you can have the phototherapy machine, but if electricity is as good as useless. So we share this study and for a discussion about ICE adoption as a way of practice going forward. Thank you all for the attention, and that is the end from us.
Great, thank you so much, Dr. Samuel, for a really nice case, and to Dr. Gilbert for a really good overview. And hopefully some of the questions that you have raised in your talk and the questions that I can see in the chat that we will address in our talk. So just bear with us, we're just going to share our screen and then we will continue. So please, everybody, feel free to put questions or discussion items in the chat. I'm Cath Harrison, I'm a neonatologist in Leeds, and I've got Gill with me.
Hi, I'm Gill Ellis. I'm one of the advanced nurse practitioners on the unit.
And we're going to talk about how we would manage jaundice in the UK. We haven't done a case because I think everybody can appreciate that most of the cases that we have with jaundice are relatively the same. So we thought we would just really try and go through some of the questions that were raised in the pre-meeting questionnaire about how we would manage jaundice. So I'll hand over to Gill.
Hi, so as we've heard, neonatal jaundice is extremely common in over 50% of healthy term infants and 80% of preterm infants. And 10% of breastfed babies, like exclusively breastfed babies, are still jaundiced at 1 month of age. Just recently, there seems to have been a re-emergence of kernicterus. Now, whether this is related to earlier discharge from hospital when breastfeeding probably isn't fully established. So all babies are prone to jaundice. The slides that you can see here, the slide labeled A shows you the yellowness in the basal ganglia, which shows you the kernicterus, and the other side is the normal one. So why are babies at risk? So term babies and preterm babies are at risk due to their red cell turnover and their shorter lifespan. So the adult red cells last about 120 days, term infants anywhere between 50 and 85 days, and preterm infants 35 to 50 days. The racial groups, sort of Eastern Asian groups, are more at risk. They have a higher bilirubin level at birth anyway. And blood group compatibility. So we have an increased circulation of bilirubin. One of the main consequences of jaundice is the feeding difficulties, and a lot of it is related to inadequate nutrition and increased absorption from bilirubin from the gut, with a limited capacity to excrete bilirubin, and the inactivity of the UDTG enzyme, which is needed for conjugation. So in the UK, we're quite fortunate in antenatally, a lot of the mums are screened for any risk factors of hemolytic disease, maternal blood group, and any antibodies. So we also know to look out for these babies with ABO incompatibility or rhesus disease. And immediately after birth, the cord blood is sent for a full blood count and bilirubin. Postnatally, diagnosis is usually initially visual inspection. We do have the use of transcutaneous bilirubin, but we only use this in babies over 35 weeks gestation and over 24 hours of age. and in babies that haven't received any phototherapy. The standard for us, though, is serum bilirubin, which is sent to our labs. So these are just some images of how phototherapy was started. The one on the left of 1958 was actually Dr. Kramer's, and the one on the right is what we use now on the unit. As you can see, there's a massive, massive difference. So phototherapy, we've already heard how it works. There was a Cochrane review that came out in 2023, which is analysis of 12 RCTs, including 1,600 babies. And it was looking at the difference between intermittent and continuous use of phototherapy in bringing the bilirubin levels down. Continuous is also seen to be more effective in the preterm infants, and all of our babies on the unit are kept under continuous phototherapy. In this trial, there were some safety outcomes which weren't really addressed. And as usual, in any Cochrane reviews, more investigations and more trials are needed. So the efficacy of phototherapy. So the light intensity which is recommended should be 430 to 490 nanometers. And the distance of the light should be 30 to 45 centimeters. So the ones that have been identified as the most effective are the blue narrow spectral lights, which is mostly what we use on our unit, although we do have some of the white lights. So the photograph of the image that you can see in the bottom corner is our billy blankets. To bring the bilirubins down more effectively, it's related to the amount of surface area that is exposed. So we quite often will have babies nursed on the billy blankets, and we'll have an overhead light as well. Some of our babies will end up in incubators just to maintain their normothermia. And the main aim is to keep babies out in the treatment and not out of the lights for any length of time. So the nursing care of our babies, we try and keep them in underneath the lights as much as we possibly can. So we try and cluster everything together, sort of their feeds and their cares, to keep the amount of time out of the lights reduced. Some of our babies may need supplemental NG feeds if they're too drowsy to come out and breast or bottle feed. Initially, we don't tend to add any extra fluids unless the babies are becoming dehydrated, as shown on any blood sampling. The photograph that you can see on the right is our billy band that we use to protect their eyes. So it's more to protect the retina and mostly for comfort. When these babies are exposed to these lights for a long time, it can be quite uncomfortable. And the nurses remove these billy bands sort of every 4 hours to just make sure that their eyes aren't becoming dry or sore. The other issue is the babies are often naked, covered with a small nappy, and they just don't like being naked. So babies are nested mainly to keep them comfortable, but also to keep them in the correct position underneath the lights. We nurse them just in a nappy, the smallest one possible, so that the most skin is exposed to the lights. As previously discussed in the last presentation, the skin is quite delicate and they are prone to rashes. So looking through previous research and other papers, sorry, thank you, there was concerns that there could be damage to the gonads and affecting the DNA. This was back in 1979 and it's not been proven, but we still do nurse them under a small nappy, and the gonads are usually protected by the amount of subcutaneous tissue covering them. So that has been disproven. So this is the nice guidance that we use on the unit. It's really comprehensive and very, very handy for us. And this is the one that we follow. Parents can actually get leaflets for this as well. We quite often give our parents a leaflet to take home to look out for the signs of jaundice when they take their babies home. So this is the chart that we use. And in comparison to Uganda, ours are based on gestation, not on weight. And this is the one that we can access through NICE. We put their gestation in the small box at the top, and it prints the chart out for us. So the more preterm the babies are, the lower level of bilirubin they'll tolerate before they have any neurological impairment. So the blue line that you can see at the bottom is when we will initiate phototherapy, when the serum bilirubin is on or above that line. The red line that you can see at the top is the exchange transfusion line. We do get babies on this line. Fortunately, they respond pretty well to extensive phototherapy and fluid treatment. So NICE have just come out with a new guideline in 2023 that has suggested in the clinically well baby, over 38 weeks and over 24 hours of age, if the bili level is below the treatment threshold, but within 50 micromoles of the treatment line, we should measure the bilirubin again. Within 18 hours for babies that have risk factors for jaundice, such as a previous sibling who's had jaundice and needed phototherapy, or a mum who intends to exclusively breastfeed, or within 24 hours for babies without risk factors. And if the bilirubin level is below the treatment threshold by over 50, we're not routinely testing that. And it would be on visual and how the baby's feeding. So once we've initiated phototherapy treatment, we usually check a serum bilirubin 6 hours after starting it. And that's just to make sure that the bilirubin isn't continuing to rise. Then every 12 hours whilst they're under phototherapy. Phototherapy is then stopped when the bilirubin is 50 below that blue line that you saw on the previous chart. And then after stopping, we check it 12 hours just to make sure there's no rebound in the bilirubin, which is more common in babies with risk factors such as the prematurity and the blood incompatibility. So one of the main issues that we have is making sure that the nurses or the medical staff who are taking the blood is to switch the phototherapy off before taking the blood sample, as the specimens are oxidized by the bilirubin or by sunlight and can lose up to 30% of that if they're exposed to the light. So it's really important that we take the lights off before taking the samples. We did used to have a brown bottle that protected the samples from lights. We don't seem to have those anymore. So it's really important that we turn the lights off. So this is an example of a chart of a baby that we had on the unit. And you can see the small dots and the numbers showing how the bilirubin was just below the treatment line. And then it's continued to climb, and then it's bounced down and bounced up above the line. So babies quite often will rebound once the phototherapy has been stopped, and then it's reinitiated and it comes down again. And generally, as the baby gets older, the bilirubin levels seem to track along the line once the phototherapy has been effective in its treatment.
Cool. Thank you very much. So we've heard about the use of phototherapy, which is obviously our mainstay treatment for babies with severe jaundice. But I think Dr. Samuel, Dr. Gilbert, you mentioned it on your talk about the use of intravenous immunoglobulin. So the NICE guidance, which came out, was reviewed in October 23, talks yet again about the use of IVIG. And the dose is 500 milligrams per kilogram given over 4 hours as an intravenous infusion. But what they are very clear to point out is that we have to use it as an adjunct to continuous intensified phototherapy. So as Gill says, if we're going to give immunoglobulin, we have to make sure that the baby is fully exposed and has phototherapy from the top with a light, and also on a bili blanket to make sure we have good phototherapy. But NICE suggests that we only use IVIG if we have confirmed rhesus disease or ABO incompatibility. And the other indication is if, despite intensified phototherapy, that the bilirubin continues to rise by more than 8.5 micromoles per hour. So that would indicate going away from the treatment line on the charts. So this was the NICE guidance from October 23, suggesting that we should continue to use IVIG. However, there was the consensus guideline, the international guideline that came out from the transfusion groups published in the British Journal of Haematology in 2022. And this was the international guidelines regarding the use of IVIG in rhesus and ABO incompatibility. And they suggested it should not be routinely used, and only when the hyperbilirubinemia is severe and an exchange transfusion is imminent, or when an exchange transfusion is not readily available, that we should use it, but actually the role is still unclear. So a bit like the Cochrane review that we heard about before, we're actually now waiting for even more high quality studies to assess the optimal use of using IVIG in hemolytic disease. However, I would point out that in my experience, when we have used IVIG here in Leeds, that the bilirubin decreases dramatically from way above the exchange line to underneath the phototherapy line. And we know in practice that actually getting an exchange transfusion set up takes quite a few hours. And in that time, we do give immunoglobulin, because we know that actually we can actually remove the need for an exchange transfusion going forwards. So what about exchange transfusions? Well, they are our second line in the UK for severe unconjugated jaundice. And these are the babies that phototherapy is not decreasing their bilirubin. So it's still above the threshold line on the red line on the chart we showed you, or they're showing signs of encephalopathy. It's extremely rare to be done in the UK. We were just discussing here that probably in the last 10 years in Leeds, we can count on one hand the number of exchange transfusions that we've done here. However, I've probably done about 50 to 60 in my training from working overseas. So I think it's just very rare in the UK. And that's probably because we have very good availability of early diagnosis of jaundice using serum bilirubins. We also have very high quality phototherapy machines, and they are evolving all the time. And so it is very rare to need an exchange. And as I said before, that using IVIG definitely has decreased the need for an exchange by preventing hemolysis. And I think we have to remember that although exchange transfusion is very effective, it's not without risks. We know that we can have infection, we can have electrolyte disturbance in terms of calcium and magnesium. And obviously we have to have some good access in the babies to be able to take out the amount of blood and give them some blood at the same time. And it takes time to set up, not only in terms of staff, but also in the resources needed. So NICE have a section on the guidelines that we've shared about doing an exchange transfusion, and says that if you do an exchange transfusion, it has to be double volume. So that's between 160 and 180 mils per kilo of blood given. They suggest that during the exchange transfusion, you need to continue your intensified phototherapy. You must not use albumin priming, and you must not routinely give intravenous calcium. You must monitor for calcium and magnesium disturbances throughout, but you shouldn't routinely give calcium. And then what they suggest following an exchange transfusion is that you need to maintain your continuous intensified phototherapy and measure the bilirubin within 2 hours of the exchange transfusion. And again, use the charts that we've seen before to tell us when to stop treatment. There was a nice paper that came out of the Journal of Perinatology, which is really good about exchange transfusions in lower middle income countries. And we know that in lower income countries, there's a much higher rate of potentially avoidable exchange transfusions carried out. And that's potentially because of the late presentation of severe jaundice, obviously the difficult in assessment with dark skins of jaundice, and the ineffective phototherapy. And so what this paper describes is a really nice triage tool and a decision tool to actually work out which babies are most at risk of severe hyperbilirubinemia, and therefore that we can provide timely exchange transfusion in the right number of babies. So what you can see, hopefully that this projects okay on the chart, is that there is a table that you have to look at for the baby and come out with sort of the score for acute bilirubin encephalopathy and neurotoxicity. So that tells you, you look at the mental status, their muscle tone, their cry, and you come out with a score, an ABE score. And then you plot it on the table on the right-hand side, which I think potentially is a little bit blurred, but it has mild or no ABE, intermediate, and then advanced, and then you plot it against their total serum bilirubin and decide whether the baby's got risk factors, i.e. hemolytic disease, sepsis, etc., or without risk factors. And then that gives you an idea of really which babies we should be worried about. So the other thing just to cover, we've talked a lot about unconjugated jaundice, which are the babies that we would treat with phototherapy. But I think we have to be mindful about red flags for jaundice. And we have to always think about, has the baby got obstructive jaundice, which is conjugated? And this is always pathological. And there are many, many causes for this, including an interruption of the drainage in the biliary system, but also congenital infections and genetic causes. But the one that we are most worried about in the UK is obviously biliary atresia that needs to be identified early and treated early. We know that babies with conjugated jaundice generally have a normal birth weight. Their jaundice can be very variable, but the key thing is that they have a very pale stool and dark urine. And as time goes on, if this is not identified, they present with failure to thrive, and then signs of liver failure with coagulopathy, ascites, hepatomegaly, and anemia. We know that it's obviously much rarer, considering what Gill said at the beginning about unconjugated bilirubin in about 80% of preterm babies, that a conjugated jaundice is only 1 in 2,500 term infants. So it's very rare. And out of those, between 25 and 40% will have biliary atresia. And out of that group, 70% will require a liver transplantation. And what we know is that the earlier it's picked up and the earlier it has surgical intervention, the better outcome this will be. So if you do have the options to do some biochemistry tests, and I know Dr. Gilbert talked about some of these, is that you can actually diagnose a conjugated bilirubinemia relatively early. So we would do a conjugated fraction. We would do a full set of liver function tests. And we know that if you've got a decreased albumin and a raised ALT and AST, then actually that's more likely to be a conjugated jaundice and obstructive picture. We then can look at the LFTs in more detail, and again, that gives us more idea whether it's a biliary obstruction or whether it is another cause for a conjugated jaundice. And what's interesting is that the deranged LFTs that we see in a conjugated jaundice are actually related to the degree of damage, not the duration of the disease. So they don't get worse, particularly over time. It's just really how bad the liver is damaged. And then obviously we have to do rule out our other causes of conjugated hyperbilirubinemia in terms of infection and things like galactosemia. And ideally, we would like to get an ultrasound scan, a fasting ultrasound scan, to see whether we have got biliary atresia, because if so, we need to get on and plan for surgery before 6 weeks of age. So hopefully that has just given you a summary about what we do in the UK in terms of our unconjugated jaundice, which we see very commonly. And I think what we can hear from Dr. Samuel and Dr. Gilbert is that we actually manage it very similar in the UK, apart from we have much higher availability of effective phototherapy and the opportunity to do more investigations to decide the cause for the the pathological jaundice. So I'm going to stop sharing my screen now, and if anybody would like to ask any questions, then please do. I'll just look in the chat. So some of the things that are coming up in the chat are about the use of the bilirubin charts in terms of gestational age and weight. And obviously in the UK, it's very easy for us to get gestational age. And the charts that Gill showed from NICE are actually so good that you just literally click a box on an Excel spreadsheet with the gestational age and it prints out the right charge. So it's very, very easy to use.
I just add there, Cath. So I'm sorry, my connection has been terrible. So apologies to everyone. I've been trying to type replies to people's questions in the chat box. There is the lately published National Neonatal Clinical Protocols. I'm trying to share it as well. It's just taking a while to upload. If not, we'll make sure that all the attendees get it on email. In there, we use the South Africa, or we chose to use the South Africa cutoffs, which you can also use the weight of the baby as opposed to the gestational age, because many of us here in Uganda don't actually know the gestational age. So I've put those in the chat as well, so if people want to download them, but I think we can also share them around to the attendees as well. I'll make sure they get to you, but they're in the national protocols as well. And then if you don't know the gestational age, you can plot on those. And there's two charts, one for cutoffs for phototherapy and one for cutoffs for exchange transfusion.
Okay, excellent, thank you. So just another question in the chat was about how long phototherapy goes on for. I guess it depends on really their response, really. As Gill said, that we put them under phototherapy and then we check a bilirubin after 6 hours to make sure it's coming down, and then check it again after 12 hours. But sometimes it's generally they're in for a couple of days and then we stop their phototherapy, but it's very common for their bilirubin to rebound back up and they have to start phototherapy again. I hope that answers your question. We will be sending around the presentations for everyone, which have got obviously the articles that we've used to reference this, just for interest.
There's a question there that I was going to type, but maybe you could explain. Breastfeeding jaundice and breast milk jaundice, people often get confused with that. I'll type in, but if you want to explain as well.
You can explain, go for it, Cathy, that's fine.
I think the question was from Francis. So thank you for the question. And it's a really important question because people get really super confused about it. Essentially, breastfeeding jaundice is when our babies are not getting enough milk. So it's very, very common in the first few days of life, both in prematures and in term babies. So the lack of milk going into the gut doesn't trigger the gut to work, if you like. So you get an increased enterohepatic circulation, which means that we've got increased bilirubin in the blood of the baby. And actually, the best thing to do for those babies is to breastfeed them more. Or if there's not breast milk, think of alternatives such as donor human milk or formula milk if you haven't got donor human milk. It's really, really common. Conversely, breast milk jaundice is really very rare, and it's a reaction, if you like, to breast milk that causes the jaundice. And in that instance, actually, what you need to do is stop the breast milk and consider changing. But for me, I normally just don't even teach about it, Francis, because actually it's relatively rare, and really most of our babies need the milk that they want. So we should consider it if you've got a jaundice that's not getting better and you can't find a cause. But what I want to encourage everybody on the call to do is think more about the breastfeeding jaundice and babies who are jaundice, thinking about increasing the feed, or if they're dehydrated, supporting with intravenous fluid. So I hope that's answered your question.
Thank you. And I think what's important to say, there's obviously been people have got very concerned in the last sort of 10, 20 years about kernicterus. And we think that's probably due to women being discharged home much quicker than they were before. And they, as Cathy said, not established feeding. And that is probably the most common reason why we see babies readmitted in our unit on day 3, day 4 with severe jaundice, is because they have significant dehydration because they're not fed well. And I think that's just because women are sent home and they have lack of support in terms of establishing feeding.
I am a neonatologist at the National Specialized Hospital. My name is Jessica Nachivuka. The question I have is regarding the kernicteric baby. Now that we have neurological symptoms or something suspicious CNS-wise, and antibiotic stewardship at this time, should we start antibiotics because we don't know who came first? Is kernicterus purely from the hemolysis, or there's another trigger, sepsis? It's something we want to delineate because the use of antibiotics is quite hectic, the stewardship and all that. So would you, for every kernicteric baby, start antibiotics in lieu of possible meningitis, sepsis underlying? Even if it's obvious, maybe it's the hemolysis going on with the mom who is AB or Arisa's incompatibility. So kindly throw more light on that for me. Thank you very much.
Thank you, Jessica, and thank you for joining. I think for us, I mean, kernicterus is extremely rare for a start in the UK, and I think that what we have to think about is kernicterus. What it means is kern is yellow, and it means the nuclei, the basal nuclei, and icterus obviously yellow. So it's actually just a description of what you see on a post-mortem specimen of the brain. So actually we have to think about why the babies become so jaundiced to develop kernicterus. So I think most of us, if we had a baby who came in with encephalopathy, with severe jaundice, with kernicterus, then we would treat for a meningitis as well, because we're assuming that the encephalopathy that you see is due to the kernicterus, but actually it might well be due to something else. We are obviously extremely fortunate that we can get an MRI scan that shows some changes in the basal ganglia, and so we would be able to rule out relatively quickly that it wasn't a meningitis. But I think the safest thing, if you have a baby presenting with encephalopathy due to hyperbilirubinemia, it would be sensible to treat with antibiotics. But obviously,
can I just add? Oh, sorry.
Yeah, go for it, Cathy. I was just saying, and stop them as soon as you realise that it is just due to hyperbilirubinemia.
Thank you very much. Very enlightening. And just for the students on this call, because they are here, it's something that they need to learn and know. Not every jaundice is equal to antibiotics. There must be risk factors and discussions or consultations regarding the need to give the antibiotics. Thank you very much.
Yeah. Cathy.
Yeah, thanks, Jessica. Thanks, Cath. I was just going to add again for the same reason, Jessica, because we've got lots of students on the call. Don't use ceftriaxone. I know many of us in Uganda end up using ceftriaxone because we don't have enough cefotaxime, but that ceftriaxone can actually worsen the jaundice through bilirubin displacement from the albumin and cholestasis. So we need to really try in these babies with severe jaundice, or indeed any jaundice, but especially these babies, to try not to use ceftriaxone and to use cefotaxime in preference. And maybe if I can, Cath, there's a question in here that says, how to differentiate from Sharon, how to differentiate the levels of severity if you don't have access to bilirubin tests. So Sharon, typically what we'll do here, you've obviously got baby who is jaundiced but is otherwise very well. And then as the jaundice becomes more severe, you go through primarily floppiness, a little bit weak, a little bit floppy, not feeding so well, not doing so well. And if you don't treat that hyperbilirubinemia, you then progress on to becoming stiff, opistotonic, and developing seizures. And often I'll teach Sharon, it's kind of the opposite to HIE, where you start off a little bit hyper alert and a little bit hypertonic and then become floppy. Almost the bilirubin has the opposite effect. So if you've got a baby who has gone on to have seizures and become very, very stiff, and the neck is stiff, and you're finding that baby in that banana shape, which we call opistotinus, you've really got to the higher stages. If you can get those babies at the earlier stage where they're just a little bit floppy and hypertonic, in general, they do quite well with phototherapy. If you've got to that stage where they've become really stiff, most likely you're going to progress onto chronic bilirubin encephalopathy, of which one of the forms of that is our typical kernicterus, but you can get other forms of cerebral palsy and the like. So hopefully that answers your question. And then there was another one up above, Cath, that we haven't answered, which says, can you briefly describe what you used to do exchange transfusion? Do you want to answer that one?
Okay. So I'm sure, well, if for an exchange transfusion, you're trying to remove the volume, double their circulating volume and replace it with cross-matched blood. So you need some system to be able to take blood freely off from a baby and then replace it at a slow aliquots back into the baby, cross-matched blood. So you need some sort of system which would be, for us, would have either an umbilical venous catheter in, and ideally an arterial catheter to be able to remove blood and at the same time push some blood back in. We need the baby needs to be fully monitored. The baby obviously needs to be under phototherapy, and we need a blood warming device is what we would use to make sure the blood that we're giving in, transfusing in, is at the same temperature of the baby. So it's quite a complicated thing, and I think the main thing that is important is that when you remove the blood from the baby, you do it in very small volumes and you replace very small volumes back in. So if you imagine a term baby, we need to remove 500 mils from the baby and give them 500 mils back. And actually it takes a really long time. And so one of the difficulties and the constraints is that it takes two members of staff, one performing the exchange transfusion and the other member of staff actually taking close observations on the baby, taking off some blood samples during the exchange transfusion to monitor things like calcium levels, potassium levels. And I would think that majority of our trainees and potentially even paediatricians in the UK have never ever done an exchange transfusion because it's so rare, because we have such good phototherapy and we use IVIG. So as I said at the beginning, it's very difficult in terms of staffing constraints, equipment constraints, and actually the time just to get things set up, and then the time it takes to take an exchange transfusion. I hope that answers your question.
Yeah, and then maybe to add on, I'm not sure the level of neonatal that you're working at, but at least when we wrote the national neonatal protocols last year, and apologies, they really won't send in Zoom. It doesn't like it. We'll send them on email.
Yeah, we can send them.
But exchange transfusion, we really decided should be done at level 3. So, or level 2.5, if you like. But I think one of the huge challenges, at least in Mbali, that we've had is hypothermia, as Dr. Cath has alluded to. Almost all of our babies in the absence of incubator or blood warmer at the end of an exchange. And I don't want to say it like we do it all the time, maybe like once a year in a really tricky situation, but they all end up cold. And the other thing to say is that these babies need good access, ideally an arterial line and a venous line. And because of the delayed presentation that we have in Uganda, many of these babies no longer have access to umbilicus. It's all dried up and shriveled away. So you need to have the skill to be able to get a peripheral arterial line in order to do the pushing and the pulling. You're going to be taking out, like I've said, a tiny bit of blood from the arterial line, putting in a tiny bit of blood in the venous line, in the cannula, and you keep going that way. So if you haven't got a fresh umbilical cord, which probably is about 3 days maximum, I would say, then you're struggling. And also many of us don't have umbilical arterial lines or any form of venous UACs or UVCs. You can use an NG tube, but again, I would say if you don't have the skill or the experience, you can do much more harm than good. If the end of your tube ends up in your heart or your kidneys, you can actually do a lot more damage than good. So I think we should be focusing on capacity building in the level 3s and then bringing up our level 2s to be able to do it. I'm gonna ask Doreen to give us her 2 questions, and then we'll see who can answer them for us. Doreen.
And can I just ask everybody else who's not speaking just to put your microphones on mute? There's quite a lot of background noise. Thank you.
My name is Katrabe Doreen. I'm a critical care nurse. I work in the neonatal unit in Barara Regional Referral Hospital. Now, we have a very low nurse to patient ratios, whereby sometimes you have one nurse with 60 babies. So when babies are under phototherapy, we are not able to monitor completely. So we usually do task shifting, and the mothers help us with monitoring the babies under phototherapy. And my question was about the length, the average length, was because, say, for example, the UK, you have probably you have a better nurse-patient ratio, and then the nurse is able to see whatever is happening. They're able to turn the baby, they feed, they're going to do continuous phototherapy, and all is well. So I wanted to know the average length. And more to that, like you are talking about students, my dissertation is about actually phototherapy and the outcomes. So because of this task shifting, I wanted to know, I thought our babies actually spend longer. Also, another issue was about not every mother is able to afford this bilirubin test, serum bilirubin. And we usually use the Cramer's visual scale. It is easier for us if for a mother who cannot afford until they get the money. So when you use Cramer's visual scale, we usually start at about 2, at grade 2 for phototherapy. Till probably the mother is able to get the money, or sometimes when the jaundice resolves, you're like, okay, that is good. Of course, we encourage them. That was question 1. So is that okay? Would you kindly tell us how long for you it takes with all these resources compared to our resource limited setting? Thank you very much.
So in the UK, it varies. I mean, the preterm babies can be up to 2 weeks on and off that they bounce back under phototherapy. Our term babies or late preterm, sort of 36 weeks onwards, usually about 3 days of phototherapy and then a rebound. And most of the time, the jaundice has recovered by then. The odd rare ones, and particularly the ones with risk factors, it may take slightly longer, but usually it's around 3 to 5 days.
Thank you very much for that response.
Okay, then there was just another question in the chat, how often should eye complications be monitored? So in the UK, we would look at the baby's eyes every 4 hours.
Yeah.
Just to check, because we know they can get a little bit dry, and sometimes is make sure that the baby's eyes are not sort of fixed open with the billy band on.
There was an interesting question, Cath, about kangaroo, and I think that there's no good answer. I'd replied in the chat, but if other people haven't seen it, obviously we use kangaroo ideally continuously, but many of us struggle with that to maintain the temperature of our small babies. Now, many of the small babies, because of the immature liver, also high risk of, and sepsis and everything else that goes with it, but a high risk of jaundice. There's no easy answer to that one, but just from experience, what we will tend to do in Mbali is we alternate the two. So we'll ask the mothers to do 1 or 2 hours under phototherapy, 1 or 2 hours kangaroo, and they alternate. So we try and get the benefit of both, appreciating that phototherapy should be 24/7 and kangaroo should be 24/7. So I think do the best you can, and maybe someone will develop a better way to do those two things together. But thank you for that question.
Yeah, no, thank you. I agree. And also, I think for us, it depends on actually how high the bilirubin level is. Obviously, if we're way over exchange level, then we would try and prioritize phototherapy just to start off with, because we know the risk of kernicterus in a particular preterm babies is much higher, and the threshold for severe encephalopathy is much lower for that. The question from Doreen, does the colour of the eye shields used on babies matter? Not really. It's just anything that can protect the eyes. So just something that you think that the UV light is not going to go through. And ours obviously have got black on the inside, but they're specially made. But where I've worked before, anything that's just stops the light going through the material would be okay. Okay, anybody got and the eye defects caused by phototherapy? It's usually just dry eyes, to be honest with you, which is why it's really important to protect the eyes. So we don't really see any problems with the eyes. If anybody's got any suggestions from Uganda, then please let us know. But we don't normally see that, but we are quite good at putting the eye masks on. So
there was one question, Cath, about the distance between the baby. I think also from Dr. Jessica, the distance between the baby and the light. And I think, yes, we have our ideal, but I think often the challenge is that the phototherapy machine doesn't necessarily go down as low as the cot that the baby is in. So you sometimes don't actually have a choice. So ideally, I think 20 to 30 centimeters. But I think more importantly for us here in Uganda is your phototherapy machine still working? I think the guys in high income settings have nice people that come around and check their phototherapy machines regularly. But I think for us, if you can get your hand on I don't even know what they're called. Maybe Cath, you can help me there, but like a billimeter. And the billimeter can go under and tell you, is your machine actually still working as well as it was on the day you got it? Because otherwise you can be putting your blue light up and thinking, yay, I'm saving lives, but actually you're not doing anything.
Yeah, I think we've used, and in the Congo, we use it's like a photometer, and you put it underneath your phototherapy lights, and you can see actually how effective it is, and actually the distance that it's meant to be from the baby. Because I think you're right, actually. It is actually the distance is all ideal if we know everything is working to 100% efficiency, but we know that actually they don't do that and they lose their effectiveness. So they do need to be checked. There's just a question just in terms of the people from West Yorkshire. Do we do any phototherapy in the community in Leeds for babies already discharged? No, we don't, but that is a work in progress and we are looking at that. Our community midwives do transcutaneous bilirubins, but also they are now quite good at doing serum bilirubins. But we are looking, there is a project ongoing looking at home phototherapy. So I think watch this space really. Just final one from, it was Dr. Jessica about the duration exchange transfusion. I think it's like most things that cause an encephalopathy, the longer that the brain is exposed to for example, hypoglycemia or high bilirubin, the more chance you are of getting neurological impairment. And therefore, if you still have a bilirubin above the exchange, the sooner the exchange level, the sooner you can get that bilirubin down into a normal level, the better. So there is no specific duration. Basically, as soon as it is gone up, you have to be thinking about what you can do. And it might be in lower resource settings that you just need to try and optimize your phototherapy as much as you can do. But yeah, there's no specific duration that it's not beneficial. I want to say a big thank you to Dr. Samuel, Dr. Gilbert, to Gill for fantastic presentations. We will send the slides round as PDF, and we'll also send some links about some of the articles that we have discussed. But there's some really good resources. I think for us in the UK, the NICE guidance, only just updated October 23, is fantastic. And then there's some really nice evidence coming out for phototherapy, immunoglobulin and exchange transfusions in lower middle income countries, which are really worth having a look at. There will be a post-meeting questionnaire that will be circulated, and as Catherine said at the beginning, it's really helpful to get your feedback just to show how we're learning from everybody in Uganda, and hopefully people in Uganda are learning from our UK experience. I think what you can hear every time we do a grand round is that we are all facing very similar difficulties. We all manage things or try to manage things exactly the same way, but obviously staffing, resources, etc. can actually change what we do. But it's been so useful to have people's comments and questions, and so thank you very much for that. I'd just like to say again, thank you very much for joining. The next date for the grand round is going to be on April the 19th, and we will circulate the topic. But Cathy, Jolly and myself have worked out a list of topics that we will work out what we're doing in April. But we would be very much like to see you in April for the next grand round.